Hello, my name's Elijah Behr. I'm a cardiologist and I'm a researcher known as a senior lecturer, and I run the Inherited Heart Disease Service here at St George's with Professor Sharma, and we see families here with unexplained sudden deaths and with a history of heart diseases that could be genetic. Sanjay and I are similar in many ways in that we deal with the families. We do tests in the families, talk to them, take their family history. I also have a specific interest in ion channel disease, known as the channelopathies, which are the electrical abnormalities of the heart that can often cause unexplained sudden deaths. And that's a particular focus of mine because I'm also trained as an electrophysiologist, which means that I can undertake some of the electrical treatments and the preventative treatments in the cardiac catheter lab for patients that we diagnose in the clinic. We also see families as a whole here at St George's, which means that we can see the youngest of children together with their parents and their grandparents as fits the family. And if they wish to be seen in that way, then we have a pediatric cardiologist who comes and joins us. And we've been seeing children here at St George's for many years to provide that holistic approach to the family. After a sudden death has occurred, the family would have had contact with the coroner's office, an autopsy would have been undertaken, and the decision from the autopsy would inform them what the cause of the sudden death was. Now, depending on that cause, if it was thought to either be an inherited condition, such as a cardiomyopathy, a disease of the heart muscle, or there was no explicable cause, so it becomes an unexplained or unascertained death. That's what we call sudden arrhythmic death syndrome. And in that situation, it's possible that an electrical abnormality caused the condition, or occasionally a very subtle form of heart muscle disease. That should prompt the GP to refer the patient and the family in. So that would potentially result in parents, siblings, so brothers and sisters, and children of the person who died suddenly being referred to us for assessment because of the possibility of one of these genetic conditions. We will then assess them in the clinic. That will include taking a full history from all the family, examining them, undertaking some of the tests that we do here, the ECGs, 24-hour tape recordings of the heart, echocardiograms, the ultrasound scans of the heart. We also undertake specialist ECGs, exercise tests, and adrenaline tests as well. There's a special tests that are used to diagnose specific conditions, and we also do adrenaline tests here as well. And these are all related to trying to diagnose the underlying cause. And leading on from that, there might be additional tests. For example, magnetic resonance scanning. That's a particular type of heart imaging study. If we find a diagnosis, then we think about the genetic test in a family member. When we diagnose a condition, there are a range of genes that might be responsible for that condition. And so we take a blood sample, or occasionally just a spit or a mouth swab from younger people who don't want to give blood. And we will take that to the genetics lab, extract the DNA from that sample, and then we can study that DNA by breaking it up and looking at the specific genes that can be involved in those conditions. And then we sequence those genes, which means looking at the spelling of the DNA to look for any misspellings. And if there are misspellings, we call those mutations. And if we are clear that that mutation may have caused the condition that we found in that family member, then we'll be able to test other family members and potentially consider that as the cause of the sudden death of their relative. If we are able to diagnose a condition to begin with, it's always done on clinical grounds, on the basis that they have the ECG or the echo abnormality. And if we have that information, that immediately allows us to look at other family members. Now, what a genetic test does is if we're able to identify that early on in a family, then we can just use the genetic test to predict whether somebody carries a condition or not, and therefore exclude them or include them from needing any testing in the future. Now that's very important because a genetic test will give ultimate reassurance to some people and will let us know who we need to focus our resources on. And so there are psychological and potentially also beneficial implications financially for the NHS, for example. There is also another side to genetic testing that we haven't touched on yet, and that's when we deal with genetic testing in the individual who died suddenly. And that's something that we call the molecular autopsy. The molecular autopsy is undertaken on a bit of DNA that we've been able to rescue from the autopsy itself. That usually requires the pathologist to have kept back a sample. That's a difficult thing to do at a time when the family are really struggling with what's happened to them, but it's an important step that we encourage, because the molecular autopsy may be a way of making a genetic diagnosis with a genetic test before we've even seen the family, and give us an important information that can help their management right from the beginning. And that's what we are looking at studying in research, as well as trying to use in our clinical practice in the clinic. So identifying that misspelling early on might be able to help the family in a more streamlined way, and help them psychologically understand things and reassure them at an earlier stage. Genetic testing fits into the assessment of families with inherited heart disease primarily, mainly, to confirm a diagnosis in somebody whom we've already made a clinical diagnosis. Occasionally, it'll help us make a diagnosis in someone who we suspicious of it, but don't have all the clinical evidence from our tests, the ECGs and the echoes. Now, when we've made that clinical diagnosis and then we've confirmed it with a genetic test result, we can potentially then offer that same genetic test to test for the same misspelling in other family members. That's called cascade testing. And when you cascade out to other family members, you can then identify those who will carry the condition and may develop it or may have signs of it already, and those who don't and may never therefore require any follow-up. And they can be reassured. Now, after an unexplained sudden death, we suspect about half of these will be caused by an inherited or genetic condition. That means that if the case was a child originally, that we suspect that it may be inherited from their parents. And so the consequence for having had a young death is that we need to assess parents and then consider whether other children in the family might be affected as well. If it's a parent who's been affected, who's died suddenly, then we suspect a genetic condition may be present, or the risk of it at least may be present in children. And generally there's about a 1 in 2 chance that it might be passed on to a child. And so we assess children from that perspective. Now, these conditions can be difficult to detect in children or be less significant in some children, in some cases. And so we often do a limited range of tests that a child can cope with, rather than putting them through distressing and unnecessary tests. It's important that we identify genetic conditions in families and therefore test for them, whether it involves our clinical tests, our ECGs and echoes, or genetic testing, because if we do identify a condition, there is still a risk for sudden death in those individuals who still carry it in a family. Just because nobody's had a symptom doesn't mean that they may not be at risk. So that really needs to be assessed. And there are many things that we can do to help someone without necessarily having to put them on tablets or give them aggressive treatments. There are things to do such as avoiding excessive exercise, avoiding certain medications that can make a condition worse, and treating certain other conditions that can also make it worse. Say an upset tummy, for example, can make things a lot worse in some conditions. And we can step in and help. If an inherited heart condition is diagnosed, it doesn't necessarily mean that you're at risk of sudden death. That is part of the evaluation. The evaluation is there to determine what level your risk is. And by far the majority of people do not have high risk. Having said that, there are some minor adjustments to lifestyle that most people will find easy to deal with that don't require medical treatments that will help to reduce somebody's risk even more so. What happens when you don't find a gene is important because our genetic knowledge is currently limited. So for example, for one of our conditions, long QT syndrome, in about 70% of people, so 7 out of 10 people who carry the condition will find a genetic abnormality if we look for it properly in the DNA. In another condition, Brugada syndrome, only 1 in 5 people will we find the genetic problem, the gene abnormality, if we look for it. So just because a genetic problem is not detected, that misspelling is not detected, does not mean that the person doesn't carry it. That's why we always base our assessments on what the signs are in the patient, in the person, the ECG signs, the echo signs, the clinical signs. If we do find a gene abnormality in someone, then that can explain their underlying condition. Occasionally those gene abnormalities are misspellings that we don't understand, and we'll have to try and assess that further in a family to try and decide whether it has caused the condition. Now, if it has caused the condition, then we can offer that to other family members to test them, and we can also sometimes learn from that misspelling of the DNA and the gene involved how we might be able to treat that patient better, and in some ways determine how their risk might be affected. That's particularly helpful, for example, in the long QT syndrome, where there are different subtypes that we can treat slightly differently, and where the outlook may be slightly different depending on what type of misspelling you carry. Genetic testing and genetic research go hand in hand. They are on the cutting edge of technology, and as technologies continue to improve, we learn more and more. So every time we do a genetic test, we consider and ask a family member that they might contribute to research their information and their DNA. And we use that anonymously, but in a way that we can expand our knowledge, find other genes that might be involved where we don't know the full genetic complement in a condition, and also find out if there may be markers that might help us to determine the risk in a person and in a family afterwards. So genetic research is going to be very important in helping with further diagnosis and helping in further risk stratification, meaning who's at lowest risk, who's at highest risk. A genetic test is a major decision for many people. It has implications for them. If you have a genetic diagnosis, it can affect you financially and personally. There's a degree of responsibility associated with it. So we always counsel our patients before they have a genetic test undertaken, and they're free to say yes or no. We explain the benefits, we explain the disadvantages. I've given lots of answers about the advantages. There are potentially some disadvantages, so that always needs to be considered, and nobody will be forced to have a test. The implications of a genetic test are very important. For the person who undergoes a test, they've usually already had a diagnosis made, the first person in the family. We call that the index case. And it doesn't normally have any major implications for them, but it does have implications for their family. So they have to consider that before they undertake genetic testing. They then have to consider offering that to their family members, to their parents, to their brothers and sisters, to their children. And that immediately brings the risk of diagnosing people with a condition and labeling them with it when they might never have been diagnosed with it if it hadn't been for that genetic test. And that can potentially have implications for finance, for insurance, for medical insurance, and have psychological implications. But then there are the potential benefits. And the benefits are knowing that you carry something that, for which we can do a certain amount, and sometimes we can do a lot for. The genetic testing can take a while depending on how many genes we have to test. The times, however, are starting to reduce. We used to be waiting 6 to 12 months for a test. Now we're waiting around 3 to 6 months, depending on how much testing is required. But with the new technologies, I think we'll be waiting less than a month in the future. So that's going to improve. And if we don't find a gene, then we either consider whether research might be able to find a genetic abnormality that we've not known before, or wait until more genes are known and then do testing for that family on the basis of the new genes. In the event of an unexplained sudden death in a family, there are two important factors to remember. One is that there's potentially genetic risk in other family members, and immediate blood relatives need to be assessed. And that's important for GPs to know. The second important thing is to remember that, difficult as it may be, it's important that tissue be retained at an autopsy, whether it's for examination by an expert or whether it's for genetic testing. It can often be an important answer in a family.